to this event on failure demand, where we're going to be asking the question, can we learn from the work that shouldn't happen? It's an important topic. It's an important time to be exploring this topic as well, given the challenges on NHS services and social care services and public sector services more generally. So we're going to be exploring this work, presenting some of the work that we've done in collaboration with our partners at the Health Foundation. I'm Fraser Battye, I'm the Head of Policy at the Strategy Unit, and I'm going to be chairing today's session. For anyone that doesn't know the Strategy Unit, we're an NHS team and we specialise in applied analytical work, and that means many different things. Sometimes it means analysing the concepts that we then go on to apply, and that's certainly the case with this work that we're going to be presenting here on failure demand. We've got 4 absolutely excellent speakers for you today. First of all, we're going to hear from Alison Turner, who is the Head of Knowledge Mobilisation at the Strategy Unit and who led this project. She's going to be telling you what we did and what we found, and will help to set the scene for exploration from our other panel members. We'll then hear from Jacob Lant, who is the Chief Executive at National Voices, who has also written a blog on the Strategy Unit website, responding to this work and teasing out some perspectives that he'll be elaborating here, where he's going to look at failure demand through the eyes of the patient. So we'll be hearing what the patient perspective tells us when it comes to failure demand. We're then going to hear from Anna Parry, who is the Managing Director at the Association of Ambulance Chief Executives. And she's going to be telling us how failure demand shows up in the work of the ambulance service, which, as we'll see, is at the sharp end of some of these issues, and some of the consequences that show up in the work of the ambulance service are horrifying and fascinating. And then finally, we're going to hear from Stephen Rocks, who is the head of the Secretariat at the Health Foundation's Productivity Commission, which has produced some completely excellent work on productivity, helping us to see what it is and how we might measure it and how it plays through into the work of the NHS. And he's going to take the productivity lens on failure demand and look at its causes and consequences and touch on some of the questions of measurement. So the way we're going to run the session then, we're going to hear from each of those speakers in turn. They'll talk for about 15 minutes or so, and then we'll see how time goes. I may then invite them to comment on each other's presentations, or I may go straight to question and answer. So what I'd like to just advertise briefly to you is the Q&A function that you should be able to see. So please put any questions or comments you've got into the Q&A function. And then one useful feature of that is that you can uprate questions. So if you can see a question that someone's asked that you particularly like, then if you uprate it, it will get to the top of the pile. And then at the end of the session, I can start to put those questions and topics to our panel members. So that's all I wanted to say by way of introduction. I'm now going to hand over to Alison, who's going to take us through the work that we did and the findings that we arrived at.
Great, thank you, Fraser. Hopefully that screen is showing up now. I always worry about sharing screens. Thanks very much. And hello, everybody. Thanks for joining us. It's really good to see so many people on the call, actually. So hopefully we'll have a really good discussion today. So failure demand is kind of a deceptively simple concept, but quite tricky and complex in practice, I think. So today I'm going to share some of what we've learned and hopefully provide a bit of a starting point for thinking, discussion and some collective sense making. So today's webinar is the culmination of a small project commissioned by the Health Foundation, as Fraser said, and we set out to explore this concept called failure demand and what it might mean for productivity and value in the NHS. So as you're listening today, I'd encourage you to think or reflect on your own context and where you might see demand that arises because needs weren't fully met first time round, and what that might mean and what that might be telling you. So I'll just give a little bit of background about myself because I think it helps set the scene for, I guess, showing where I'm coming from in terms of how I've approached this. So my role is a combination of evidence synthesis and knowledge mobilisation, and that's essentially bringing together different sources of knowledge to inform policy and decision making. And I'm particularly interested in what happens to knowledge when conditions are difficult. So when systems are under strain, and when systems are fragmented, for example, and also how we value lived experience alongside clinical expertise, practitioner expertise and community expertise together alongside research findings. So that's a little bit about why I was interested in failure demand or exploring this concept, and really gives a bit of a sense to you where I've come from, how I've approached this as well with colleagues. So I wanted to start by thanking the Health Foundation for commissioning this project, and particularly Francesca and Ellen for supporting us throughout the whole project as well. I'd also like to thank, there's a long list of people in our report who generously offered their time to share their reflections, their experiences, their expertise. And that's been so helpful in us, helping us to sort of make sense of what this is and what it might mean. I also want to call out Matthew Meze as well, because he deserves a special mention. He has connected us with so many people in so many different perspectives that it has really helped us out. So failure demand, many of you might be familiar with this term. In case you aren't, here are the definitions that seem to be most widely used. And failure demand sort of stands in contrast to value demand, which is really what a service or a system is set up to do. That, you know, it's raison d'etre, if you like. Whereas in contrast, failure demand is the extra burden created when the system fails to deliver or respond to needs fully the first time round. And it's kind of a signal of systemic issues that are sort of baked into processes, interfaces, services, so really baked into how we work. And that really becomes a problem because it affects how we can manage demand effectively. So these terms date back from the 1990s. John Seddon sort of coined these terms. And I think it was initially a telesales context, but the concepts have been applied since in lots of different services and settings, obviously including healthcare. And we were kind of interested in understanding if it would be a useful way of framing some of the productivity and value challenges we currently face in the NHS. I think it's important to say failure demand is not about individual performance. So it's really about how well a system is working, how systems are designed, and the extra work that design can sometimes create, sort of inadvertently, I guess. Now, it's a bit of an abstract concept, so we sought out lots of different examples to help us sort of get a sense of what it is and what it isn't. And you'll find a lot of these in the report. But just to give you a couple of examples. So one we came across was a parent trying to book a vaccination appointment for their newborn baby. It took 4 phone calls and a complaint to the practice manager before they could get an appointment. And in the meantime, they're getting all these reminders telling them to book an appointment, but not being able to because the appointments weren't open or they'd all gone. And at a sort of more system level, we could think about the people, you know, waiting on waiting lists whose conditions deteriorating, and they're then needing more complex care and potentially more costly care too. And that's probably a familiar problem at the moment. So the concept's been around a while, and you're probably thinking, well, why now? Why look at it now? And I think for us, the starting point was this sort of productivity paradox that you'll recognise. So NHS activity is going up, our appointments are going up, our referrals are going up, and the number of tests we do. But the outcomes aren't necessarily keeping pace, and neither is patient experience or staff satisfaction either. So the standard response to that might be, let's just do more and do it faster. But we wanted to ask a sort of slightly different question. So what if a significant proportion of this activity doesn't need to happen at all? So very briefly, just so that you've got a sense of how we went about this, obviously, with my background in evidence synthesis, I'm always going to start with a literature review. So we looked at policy and academic sources across multiple different disciplines. So drawing on improvement science, health services research, health economics, for example. And then we followed that up with interviews with about, I think it was 22 experts. So researchers, system leaders, consultants, all with expertise in failure demand across different sort of settings and services. And then lastly, a stakeholder workshop with 17 people from various different backgrounds that really helped us to sort of test our findings. And I'll share some of our draft typology shortly. So a deliberate feature of the way we went about this was to bring in diverse perspectives. We spoke to people who work in different settings and who've got sort of different disciplinary backgrounds. So we had people who come from an engineering background, people from a clinical background. Some people had both, which was really interesting, and also people who work in sort of improvement and quality improvement as well. And I think that really helped us to make sense of what we were seeing, test our thinking, and then reflect on, how this might be useful in the current context. So when I started the work, I really expected it to be about productivity, but actually I think what emerged was really a story about the impact on people. So these are 4 dimensions that came through from our research. So first, I think, and foremost, was this sort of hidden burden on patients and carers. So the sort of time, the money, emotional energy that it takes to navigate this sort of fragmented landscape. At our roundtable discussion, we talked a lot about end-of-life care, and I think there is evidence from a select committee about patients feeling they have to go into battle with the system. Carers are having to give up work to help navigate the healthcare for their loved ones. And none of this sort of work of being a patient is captured in our productivity metrics. And it creates kind of a perverse incentive. So if a service or a system wants to address this burden, then it could end up showing up as a cost rather than a productivity gain. I think also the workforce impact is really important. So when our workforce is sort of continually engaged in dealing with this sort of avoidable demand, it kind of erode a sense of purpose. And I think, and we heard a lot about clinicians feeling they were sort of almost like working in mechanized roles, and this sort of culture of defensive practice emerging, and that sort of leads to attrition, burnout, and obviously that reduces capacity, but it also risks further failure demand and risks to patient safety as well. Thirdly, equity was a key theme that came out particularly in the literature. Actually, this idea of sort of equality-based models not working for people with particularly complex needs. So while they work maybe for most patients, there are a lot of patients who have complex needs that the thresholds and the processes and pathways are a little bit too rigid, maybe not flexible enough to adapt to their needs. And then that creates a sort of cycle of repeated presentations and maybe even crisis presentations as well. And then lastly, we looked at some of the impacts across the system. So failure demand doesn't stay within neat organizational boundaries. It sort of all these unresolved needs will resurface somewhere else, often in more urgent or more costly forms. So this is the sort of central output of what we did in the project. This is a typology, a sort of exploratory typology of how failure demand manifests in healthcare. So it kind of, I suppose you could describe it as kind of like the signs and symptoms of failure demand, really. And we've done this across sort of 2 dimensions. Because we found really that the concept resonates with people, but it is quite messy. So the terminology varied, the way that people describe failure demand varied a little bit, and there's probably some quite strong opinions about what it is and what it isn't and how to go about addressing it. But the evidence base is relatively underdeveloped. So what constitutes failure demand seems to be quite contested, but actually there is still a lot of common ground about the underlying causes. So this typology was our sort of attempt to try and make sense of what we were hearing from people. And it's sort of based on this premise of healthcare as a socio-technical system. So on the horizontal axis, we've got, sorry, I moved forward too quickly there. On the horizontal axis, we've got the nature of the interaction. So is it sort of more predominantly transactional? So that might be something quite discrete and bounded, like booking an appointment, through to sort of relational interactions. So this might be more around complex needs where continuity and contextual understanding is so important. And you might have heard about this concept of relational density, which is how much relationship is needed for a service to work. There's a really good post on LinkedIn by Joseph Badman on this. So the further you go to the right of that matrix, the thicker that density is. And then the second dimension we've got is the vertical axis, which is the locus of the failure. So is it showing up within a service or across service interfaces? And then these 2 dimensions give us 4 domains, and the point of doing this is that they sort of warrant different responses when the failure demand is identified. So I'll just quickly run through each of those in turn, but you'll find more in the report. So starting at the lower left quadrant, we've got operational frustration. So this is your sort of booking problems, supply issues, communication gaps. And I think we've probably all experienced these in one way or another, you know, letters arriving after the appointment and things like that. And these seem amenable to process improvement. So you can map the process, figure out where the issue is and resolve it. If we move across to the sort of more relational side, we've called this quadrant rule-bound services. So these are sort of the rigid eligibility thresholds. And the Nuffield Trust did some really interesting work last year on continuing healthcare, and King's Fund have just published something on this as well. And they're both really excellent examples of this. But also there are support gaps. So where people might need home adaptations, for example, or access to interpreters, and that's just not available. So I think there's something here around understanding those needs, but also building in feedback loops to spot where there are issues. And then if we move up towards the sort of failure demand that shows up at the service interfaces, so delays and blockages show up. Either we've got flow disruption, long waits generating more demand downstream, and these sort of issues really warrant system level redesign. And then moving across to the upper right quadrant, disjointed care shows up as poor transitions, loss of continuity, and what I think there's a really good term that Changing Futures came up with called pixelation, where that services focus in on one small part of a person's need rather than sort of entirety of it. And so it's sort of dealing with a very small part rather than thinking about the whole. And these sort of problems warrant an adaptive cross-organizational learning response. And there's some really interesting evidence emerging in this sort of sector, this quadrant, around relational care and relational services. So work like the Changing Futures in Northumbria, but there's a lot coming out on that. So I think the key message is that matching the response to the signal matters. So if you treat a relational cross-boundary issue as a sort of process issue, it's just not going to work. And what we're really aiming for here is just to give people a practical starting point for identifying and recognizing failure demand and thinking about what would be an appropriate response. So it's not really trying to close it down into categories. It's really about opening up so that we open up our understanding, I guess, really. So just coming back to our sort of aim of the project, we asked if the concept of failure demand could help improve the NHS, and our answer is yes, but with caveats. So we think failure demand is probably best served as a sort of lens for looking at value and productivity. It's helpful to sort of prompt curiosity, to start conversations and to spot patterns in demand. And I think it's an opportunity for us to better understand how much what we're doing is avoidable, and whether some of the activity we're seeing is actually the system responding to its own gaps. So what I hope might change is a different view of productivity. So recognizing that activity can increase while value stays flat or even falls. So some of the experts we spoke to talked about failure demand as a way of understanding the productivity paradox that we're seeing. So not just how much we're doing, but how much of this actually adds value. So ultimately, I guess what we're hoping is that this report helps trigger conversations in teams, organisations, systems. And in that spirit, we've offered a few recommendations for policymakers, system leaders and researchers, which you'll see in more detail in the report. And I'm just going to show you the links to the reports there. So the QR codes, you should be able to just click on those and it should provide access to the to our report and also Jacob's guest blog as well. So just one final reflection from me before closing. I just want to reiterate that addressing failure demand does depend on a culture of learning and collaborative working. It isn't about apportioning blame, but very much about seeing the system more clearly. And that's the end of my session. Thanks very much, Fraser. I'll hand back to you.
Thanks, Alison. That's excellent. I've seen lots of questions pouring in. Some of the questions around methods. So perhaps if people go to the report, they'll be able to see the detail of what we've produced there. That sets a really nice overview for us. We're now going to go to hear from each of our speakers in turn. So Jacob, could I invite you to offer your reflections on failure demand, and we're taking here the patient perspective on the way in.
Thank you, Fraser, and thank you, Alison, for that overview. So delighted to be here. My name is Jacob Lanton. I'm Chief Executive of an organisation called National Voices. If you've not come across National Voices before, in short, we are a coalition of health and social care charities. We've got about 200 members, representing two two groups. So your traditional health condition charities, so those working on diabetes or cancer, dementia, and we combine those with members representing different community groups, often communities who are having worse experiences and outcomes at the moment, and at the sharp end of health inequalities. We sort of merge those two groups together and create opportunities for people with lived experience across those groups to come into rooms to share their insights and to help make policy in health and social care better. And so failure demand for me, when I was kind of getting was involved in the earlier stage of this work, some of the principles just resonated so strongly with what we hear on a daily basis from those people that we work with. And so I'm going to share a few reflections, which I hope are helpful. And I thought I'd start by trying to paint a picture of what a real life experience of care pathways looks like for patients. And some of this would be defined as failure demand. Some of it might be defined slightly differently, but useful to see how what you can spot in here is what you would think is failure demand. So imagine a patient who's developed new symptoms goes to see their GP. Those issues can't be resolved in primary care, and so there needs to be a referral onto secondary care. For about 40% of patients, that happens really quickly and efficiently. So one visit, in their first visit to the GP, they'll be referred onwards. Now, we can have a conversation later on about whether referring immediately in that way is efficient or not. But on the surface, it's very efficient. Those patients get referred first time. About 80% of patients get referred within 3 visits, which for me feels like a fairly reasonable number of visits to a GP. It's understandable that you wouldn't necessarily get a referral on the first visit. You might want to order additional tests. You might want to try different things in primary care before you refer on to secondary care. So 3 visits seems reasonable to me, and largely to the patients who are engaged in this piece of work we did on referrals. But for 1 in 5 patients, it takes more than 4 visits to the GP to get that referral. And that's largely driven by issues around continuity of care. So if you've seen 4 different GPs on those 4 different appointments, it can be hard to get that referral. So we see issues in how quickly people are getting referred. Actually, it's quite a prominent concern, and that has a time consequence to people. So for 1 in 10 patients, those having to get those multiple GP appointments to get their referral, that can take them up to 4 months to be referred onto secondary care. And all of that, remember, that 4 months sits outside of the RTT target. So that's the 18 weeks measured from the point that your referral has been received. And so that earlier wait is invisible on what's happened to you. Now, that's not the end of it when you have your referral. So we know that for 1 in 7 patients, for whatever reason, their referral goes missing. It goes into what we refer to as a referrals black hole. And thank you. I'm just being given some post by my daughter under the door. So yes, for 1 in 7 patients, they're going to this referrals black hole, and that results in patients and families then trying to chase up the referral, working out where's it gone, what's happened to it, and that has a knock-on effect on services because they now have to spend more time dealing with those admin requests. So all round, it's a very frustrating experience. And remember that 1 million patients are 1 million referrals a month, roughly, between primary and secondary care. So when 1 in 7 referrals are going missing and resulting in this admin burden and follow-up, it's a huge demand pressure on the system that's largely invisible at the moment. Once a referral has been received and accepted by a hospital, that, as I say, that's when the official waiting period starts. But if you look at the ONS Health Insight survey, that shows that only 1/3 of patients know when their appointment to be seen actually is, and the rest of them are left in the dark, which again results in this people following up, asking questions, where am I on the list? It creates the failure to meet that information need is creating a demand on the system that admin staff have to respond to. And now, we did some recent joint work with the King's Fund on admin, and actually found that, rather staggeringly, 1 in 5 patients who've been referred for appointments actually miss that appointment because the letter with all the details about when it was, where it's going to take place, all that actually arrives after the time the appointment was arranged for. So a fifth of patients are getting the letter after the appointment. The knock-on effect of that is that 42% of those patients who experience that specific problem are less likely to seek care in future. So they'll arrive as some other a more complex demand need at some point later in the future. But even for those the patients where you might argue the system's worked perfectly, we identify problems. So if you take someone who got referred by their GP at the first attempt, they got a letter clearly stating early on when their appointment was going to be and the logistics, so they knew all of that, and it all happens within an 18-week time frame. We might, as a system, judge that we dealt with that person efficiently and effectively. But we often hear through our members and directly that patients don't always know why they've been referred. So they can turn up at the appointment and not be clear, or they do know why they've been referred, but they get to the front of the queue and they're told the service they've been referred to isn't actually the right one. And they're going to have to go back to the queue, back to the front of the queue for a different service and start all over again. So in that context of that sort of pathway I've just sort of presented, you can see why patient frustrations are growing, and you can see why probably public satisfaction is where it is as a result. And I think there are several touch points in there that you could constitute as failure demand. But they are the everyday experiences of navigating the NHS. But when I say I've been working in patient and public involvement for a long time now. I've been doing about 15 years. And when I share insights like that sort of sequence I've just shared with you, the feedback I often get from decision makers and professionals tends to be one of two things. It's either we already knew that, and I'm like, well, if that was the case, why haven't you done something to fix it? Or they start to try and undermine the evidence base. They'll say, well, that's not from official stats, or that's anecdata from patient experience of something that's gone wrong. It's not reflective of all of the patients who go through the service. And actually, for everybody, for the majority, it's fine. And I think that's a real problem to have that mentality. But I think that we get those two responses because we're often pointing to things that everyone knows deep down they're not working, but it isn't any one person's job to fix it. I think it's also, I think Alison touched on this a little bit, that the NHS is also not the one that's paying the immediate price for failure demand. It's often the patients who are having to, we put greater demands on their time because we're requiring them to do more appointments to achieve the same outcome, or we're asking them to cope for a long period of time with unmanaged symptoms. And so it's the individual that pays the price in the immediate. And when the NHS does pay the price, it tends to be in patients presenting late with more complex needs, and then drawing the dotted line between the earlier opportunity to intervene and the later consequences of not having done that. It's hard for services to do that. And I also guess that for me, that's one of the things that worries me about the failure demand conversation, is that whilst it's a useful framing for the NHS to kind of get its corporate head around the everyday failures that patients are experiencing all across the system, there is a risk that what the NHS will do is it will go to its comfortable space of trying to quantify the problem. It will try and think, how do we quantify it? How big is it? Can we prove it's a real issue? If we fix it, is it going to result in the efficiency savings that we want it to? And I think that hunt for evidence can be sometimes a bit of a delaying tactic. And particularly when the problems we know just deep down they need to be fixed. And in general terms, we already have a lot of evidence. We know patients repeatedly tell us that they can't navigate services. We know that people miss communications. We know that people have to access their own care coordinators. So we have this huge evidence base, but it's maybe not the evidence base the system sees, or it's not the evidence base. It's not sort of packaged in a way that the system recognizes. And what I don't want the system to do is go and try and create its own evidence base to prove that we need to fix failure demand. I think the focus and attention has to be more on culture, particularly around this idea that I think we have a culture of tolerating these failure demand, and we have a lack of courage of trying to fix it. We'd rather go and research the problem in more detail than the courage of trying to actively think about, how are we going to fix this. I think a lot of this is reinforced by our traditional thinking on productivity. So we tend, as a system, the NHS tends to think about productivity as about doing more appointments, more activity, more throughput. But we know that patients don't experience productivity in that way. It's for them actually getting the right support at the right time without having to feel like they're fighting the system to get that. That's where they feel that they're getting a genuinely productive and efficient service. So that leads me to kind of put a couple of questions forward I think we can consider as we get into the Q&A element of this. What if some of the biggest productivity gains that we could make in the NHS don't come from us doing more? What if they come from us actually finally deciding and having the bravery to fix some of the things that we've just learned to live with, all the sorts of things we just accept in how the service is a bit pants at the moment, and that we're not going to accept that anymore. So there's a bit of the cultural challenge here, because when we look at failure demand through a patient lens, that's really what we're talking about. We're not talking about hidden inefficiencies that we're trying to uncover through doing further research. It's tackling head-on normalized inefficiency that we've just grown to accept. It's not about the problems that we haven't discovered. It's about the problems that we are just comfortable with at the moment, that we just and I think that if we can get our heads around the cultural challenge of failure demand more than the trying to measure it and seeing if that's where we should put our attention, I think there's a real opportunity to drive genuine productivity improvements for the system that are more efficient and more cost effective, but also are felt better by patients and will improve patient experience, will improve patient outcomes, and as a result will improve patient satisfaction. And I think that's critical to the long-term success of the NHS and long-term support for the NHS, because right now we have a system that's not meeting everyday needs. It's failing on some very basic elements of care, and that will undermine over time public confidence in the model. And we can't afford to let that happen, because the alternative models for health services are far worse. But if we don't address these basic failures, then we'll undermine that public support. We'll take it for granted. So I think, to finish, failure demand and thinking about it as a cultural challenge is fundamental to the long-term sustainability of the NHS. And I'll pause there.
Thank you, Jacob. And your point about a sort of not wanting to elicit a kind of classic or knee-jerk response from the system to measure this out and crush it down is an interesting point and a challenge to many of us working within the NHS. So thank you for that. I'd like to bring in Anna now. Anna's going to tell us about how failure demand shows up in the work of the ambulance service. So Anna, if I could hand over to you, please.
Thank you, and thank you to the Strategy Unit for the opportunity to participate today. So I'm Anna Parry, I'm Managing Director at the Association of Ambulance Chief Executives. We represent all UK NHS ambulance services. We're a membership organisation. I first heard the term failure demand a few years ago, so from Matthew Taylor, the previous Chief Executive of NHS Confederation. And I really welcomed it as a concept, because for me it explains so much and succinctly captures a fundamental flaw of how the NHS operates. Over the next 15 minutes or so, I'm going to be sharing a few of my high-level reflections on the report, thinking about how failure demand shows up in ambulance services in practice and some of the main drivers and sources of that. And then finally, think about the impact on services, patients and ambulance service people, clinicians and people working in support services, as well as the wider system and ultimately health outcomes. So a few of my reflections, firstly, with regard to the report, which for those of you who haven't yet looked at it, I would strongly advocate that you do. It's an excellent piece of work and very accessible. So the human work that Alison's talked about underneath the figures and how invisible that is, that Jacob's touched upon too. Just to speak very briefly about a personal experience, my mum died in 2021, having had breast cancer for 17 years, which metastasized, and the amount of effort and work that she had to do, I had to do behind the scenes to ensure she got the clinical care she needed to live that long with that condition was immense, and something that we tolerated, because I knew working in the NHS that we needed to enable us to access that clinical care. But that is huge, and the price that people pay and the impact that has on people both mentally and physically can't be underestimated. The fact that failure demand is built into process design and that we get out what we put in, I think we need to remember that, reflect upon that, and that needs to inform where we go next. There's reference to failure demand's existence in services, but from an ambulance service perspective, the bigger impact is across services and systems, and very much looking at where people fall through the gaps. The productivity paradox is fascinating, and again in terms of the ambulance service particularly, with regard to more appointments, more patient contacts, so where we're busier but continuing to fail to meet demand and patient need, true patient need. The workforce sustainability piece is also huge, and of course the recognition that deferred treatment generates more cost. I think this can be overlooked, but deferred treatment generates more cost, as colleagues have already referenced. The diversion of resources to remedial rather than productive use. We need to be thinking much more about that rather than continuing to do what we've always done. And I really welcome Jacob's call for, instead of a knee-jerk reaction to how can we better quantify this, looking at what we do different culturally in order to reduce and ultimately eradicate failure demand. I think the recognition of the important limitation of volume-based productivity measures is a really important one, which can and do mask failure demand. But still count as output. And in the ambulance service, we're predominantly looked at with regards to category 2 performance. And I understand the reasons for that. And category 2 performance is really important. Obviously, a timely response to the statutory standard is 18 minutes, but we're currently working to a 30-minute standard. That's obviously fundamental with regards to patient experience, patient outcomes, but how we end up with a very blunt, one-dimensional metric to capture everything that's going on within a system, and how that can result in perverse behaviours rather than ones that are ultimately about the best care for the patient. We need to distinguish between genuine need and activity generated by system shortcomings, and really differentiate between that patient need versus demand. So for me, failure demand, it is an explanation of why increasing resources have not translated into corresponding outcomes. Alison's referenced her blog, which is entitled, "Is Failure Demand the Root to Success?" I really think it is a greater understanding and consideration of failure demand, and how considering it and using it to inform what we do next, it is part of the answer and route to success. So from an ambulance service perspective, the ambulance service has historically picked up a lot of failure demand, acting as what is often described as a backstop or safety net. And this is perpetuated by its 24/7 presence and availability. In the report that we're considering today, there's one example of ambulance service failure demand, which is, for those who haven't read it, ventilated patients being admitted via ambulance for routine catheter changes that are manageable in the community. This is a predictable need met by an emergency response. Now, the historic ambulance service model has perpetuated this failure demand, arguably, and its tendency to accept and tolerate it, which we've sort of referenced before, in spite of the frustrations and recognition of all too frequent suboptimal response the ambulance service provides, for the patient primarily, but also for the system. So in that example, with regard to that routine catheter change, the term cracking a nut with a sledgehammer springs to mind, when in that example, the equivalent of a mobile ED unit crewed by 2 clinicians is used to convey somebody to hospital who doesn't need to go to hospital and whose need would much better be dealt with at home. Now, ambulance service clinicians are, of course, as well as other clinicians, constrained by their scope of practice. So we have emergency medical technicians, paramedics, advanced paramedics, prescribing paramedics, and they need to operate within their scope of practice. And they are also constrained by the availability of alternative pathways. And this is a massive one for the ambulance sector, and why we often perpetuate failure demand because there's no alternative. It's the best of a number of bad options. So if clinicians aren't equipped with the skills and experience to change a catheter, and there is no community or general practice alternative that they're able to refer to promptly, the only suboptimal choice that remains available is conveyance to an ED in far too many cases. Now, most NHS provision historically is predicated on in hours as opposed to out of hours, which equates to circa 33% of the time, and 5 days a week as opposed to 7 days. So combined, this equates to 23% of the time, which means that service provision for circa 77% of the time is designed and delivered suboptimally. And of course, I'm looking at it through a 24/7 lens. All healthcare isn't that, doesn't need to be that, but much more of it needs to be looked at in that way, or in an increasing time frame than it is currently. So 77% of our time is designed and delivered suboptimally, which inevitably and obviously gives rise to failure demand when additional activity is generated because patient need isn't met appropriately when it initially presents. Now, the impact on services, patients and ambulance service people, as well as wider system and ultimately health outcomes, it is massive because of the mismatch between need and demand, with the need not being met, that detrimentally affecting demand levels and increased levels of activity. And I'm going to talk now briefly about handover delays. So this has been a priority area for ACE for many years because of the detrimental impact of long waits in ambulance queues for patients. So we did a piece of work that we published in November 2021 and found that 8 out of 10 patients will be detrimentally affected physically and mentally too, but primarily the impact on patients waiting in the community without a response and with no clinical oversight. So we've done a lot of lobbying on handover delays. Have been an issue for considerable number of years, exacerbated by COVID. And another area, we're in a different place now, that was kind of deemed to be acceptable. This is something that you know we have to put up with. The impact it is massive there on patients, on their carers, on ambulance service staff, on ED staff. The proportion of patients which arguably high waiting in queues, it is because of failure demand and needs not being met by community primary care. And that has the bigger point really here that I want to make, a direct adverse effect on ambulance response to high priority patients waiting in the community with indirect consequences. So patient death, suboptimal clinical outcomes, and then more activity. So we need to get better at understanding that not dealing with something here and leaving it repeatedly creates more demand and more patient need. Alongside that, the Healthcare Safety Investigation Branch did a 3-part study that was published in 2023, looking at the harm caused by delays in transferring patients to the right place of care. And as you'd expect, there's a huge impact upon staff wellbeing, morale and attitude. And some of the terms that came up very frequently that are referenced in that report and that we've heard in the sector over numerous years is the helplessness, the demoralisation, and as Alison referenced, the erosion of the sense of purpose. So when you're seeing so much of your time wasted and not being put to good use, when you know that there is need for that real patient need in the community, the impact that has on you, yourself, your sense of identity, your sense of purpose with regards to your profession is huge. And then on the rest of the care that you're providing when you're not waiting in a handover position. What's interesting as well, going back to what Alison said, I think what's key here in the handover delay space, what we've seen, we know we've done a huge amount of work on this and it's available on our ACE website. What's required there to move away from extremely long handover delays, and we were in a scenario frequently, fortunately to much less an extent now, but whereby you could have a crew, an ambulance crew that finished a shift waiting in outside a hospital, only to find that when they go back on shift, that patient is still waiting. So some of the waits were eye-watering, and we're big supporters of the eradication of corridor care as well as handover delays, because of course we don't want to end up in a scenario whereby you're suppressing the bulge somewhere, only seeing it popping up somewhere else. And what we've seen culturally is key to this is patient flow, looking at the whole system, that whole patient flow piece, rather than looking at it in these silos and specific parts. We've seen some great work in South Western Ambulance Service, where there's been real collaborative work with the ambulance service, with hospitals, not blaming, as Alison referenced before, but looking at how we can continuously improve it and do better, because everybody stands to gain. A few other areas I just want to reference where failure demand is very apparent. Mental health. London Ambulance Service has seen its mental health calls increase by 90% over the last 2 years. This is big. Ambulance services often aren't best placed to deal with people in mental health crisis, but we're increasingly seeing a mismatch between mental health provision and demand, and the demand profile. Another complex area, right care, right person. So this was the police response a number of years ago now to their handling of failure, what could be termed failure demand, and holding a line on not sending police resource unless there was a clear determinable police role. Now, what we've seen nationally is that the success of this is very much dependent on effective local collaboration, which is more apparent in some areas than others. There's a big risk in terms of the right care, right person policy, in that welfare checks are no longer sufficiently tasked to any one organisation, and we've seen a high number of preventing future death reports that demonstrate subsequent failings of policy implementation. Now, this is an indirect result. The impact is an indirect result of police responding to failure demand across the system, which has driven a subsequent response that has significantly increased risk for some user groups. So there are the immediate consequences, and then the additional consequences. This plays out and has a huge number of ripple effects. Another area that I wanted to reference, and it's been referenced already this afternoon, is palliative care. So we know that 6 out of 10 people use an ambulance in their last 3 months of life. And we know that too many patients are conveyed for a range of reasons that are directly linked to failure demand. So this can be 9 to 5 service provision or slightly extended, but service provision that doesn't meet the demands of end-of-life care patients outside core operational hours. This may be in primary care, community care, in pharmacy. So an inability to access medication at home that can result in a conveyance that shouldn't happen, that the patient and their carer didn't want to happen. We know that there are too few respect forms, so recommended summary plans for emergency care and treatment, and we would really strongly advocate colleagues who are working clinicians who are with us this afternoon to seek to ensure that as many people have in the end of life position respect forms in place to help us ensure that we're meeting the need of the patients in the best way. And we know, and this Marie Curie data, that 1 in 3 people die with their end of life needs not met. Another area where we see a high proportion of failure demand is around care homes, where from an ambulance service perspective, we get call outs for things that should be dealt with in residence. And that will be talking about in a second some of the work that's been done in one of our areas specifically, but as well as others with regard to better meeting that need rather than responding to the failure demand. So finally, I'm just going to touch upon the ambulance service contribution to the solution. So this is really important to me. What can we do now in response to this? So, and again, reiterating again the point that Jacob made, really important that we don't consume ourselves with better quantifying this rather than looking to do the things that need to be done now that can make a difference to the patients of today, tomorrow, in the short term, as well as the medium and the long term. So we published a vision, again, which is available on our website last year, an ACE vision, which builds on the unique selling point of the ambulance service with regard to call taking and dispatch. And we see a key role of the ambulance sector as being care coordination and navigation to help ensure that we're getting it right first time with a more intelligent and informed first response. And we this is sort of managed through in control rooms having more access to specialists. So, for example, palliative care consultants, mental health nurses, or if not in control rooms, remote access. So we can deal with the patient need firsthand rather than send them on some sort of wild goose chase to get to where they need to go, which can be too late in some instances. From an ambulance service perspective, we're moving to a position whereby we're using greatly enhanced use of clinical triage. So having the most qualified clinician at the patient interface, determining the response required. So really flipping what's gone before. So what we have done previously, and I'm simplifying things massively, but sought to, in high categorized cases, sought to send a resource as quickly as possible. Again, so we meet that time target. Now, in some instances, that's absolutely right, but in other instances, it's not. And we need to be more intelligent, more nuanced in responding to the patient need, rather than seeking to sort of serve time targets and do something that serves the time targets, rather than actually thinking about what the patient needs and getting that right the first time. And there is a tension there with the one-dimensional performance targets, but I don't think that's surmountable. So there's some great work that's been done by the Welsh Ambulance Service looking at clinical outcomes alongside those time targets. So we would never advocate in the ambulance service that we don't need time targets. We think they're essential. However, they need to sit alongside clinical outcomes and what the patient need is and what the appropriate time target is in the context of that patient need, rather than simplifying everything to an 8-minute response or an 18-minute, 30-minute response. And that point around bringing clinical expertise closer to the patient's first interaction, we see that demonstrated in the context of industrial action, which of course is really regrettable. But what we see when there is a higher proportion of consultants in EDs, ambulance performance improves greatly because things are being dealt with much more quickly firsthand. Across the ambulance sector there and beyond, more generally, there are some excellent examples of services working together and representatives stepping into the system leadership space to devise systems that work for patients and orbit around patients rather than the organisation and professions that deliver them. And I'd like to conclude with an excellent example. I mentioned care homes before, but that I'd like to come back to. So work that's being done over the recent years in CCAM, South East Coast Ambulance Service. And again, this CCAM certainly isn't on its own in this work. We've done some work at ACE with regards to this, but looking at care homes. Those of you who are going to be at Confed Expo next week, we're doing a session on Wednesday morning about this, where you can find out more detail. But there was initially a pilot, so the call out from care homes, as I've said, is generally too high for ambulance services and doesn't require an ambulance service response. So CCAM, in one area in West Kent, they undertook a pilot looking at better educating care home staff, increasing competence and confidence in dealing with some issues that could be dealt with there rather than calling out an ambulance, looking at things like death verification in nursing homes to reduce the demand, the unnecessary demand on other clinicians. And they saw in West Kent a reduction of 36% in call rate to the ambulance service. That's now been rolled out again across Kent, Surrey and Sussex, and so far there's been a 26% reduction in the call rate to the ambulance service. And the continuous improvement approach, so I think there's a massive cultural piece here, as Jacob's referenced, but their intent there is to continually improve that, working with partners, not seeking to blame, but working together to collaboratively address and put in place better systems that work better for the patient as soon as possible, because everybody stands to gain from that. So finally, I think my personal and professional reflection is that failure demand is a hugely helpful lens through which to view existing health and social care practice and how we can do better. And we need to get to a position whereby patient need is at the heart of what we're doing and why we're doing it, rather than demand. Thank you.
That's great, thank you. And there's some nice illustrations of sort of systemic issues in there, and also nice precise examples of approaches to addressing failure demand. Finally, then I'd like to invite Stephen in from the Health Foundation and the Productivity Commission. Stephen, you're going to give us the productivity perspective on failure demand.
I am going to do that, yes. And I think I'll be repeating some of the points that we've heard thus far, because I think there's a lot of overlap between what participants have said, but I will firmly ground it then in thinking about productivity. For those of you who don't know, the Health Foundation is running an NHS Productivity Commission. We've been running for about a year now, and we'll be reporting back in September. And what we're trying to do through this project is not identify a long list of interventions, be that virtual wards or anything else, but really to understand the conditions in which the NHS can become more productive and can continue to do that over time. I'm not going to say too much more about the Commission's work as such, but there is a link there if you want to go to our webpage. What I will say up front, and again, this tallies with what we've heard from other speakers so far, from the perspective of the Commission, we're very much viewing productivity as getting better outcomes and experience for every pound spent. And I'll come on to talk about how productivity is currently measured, but that's very much how we have understood that. It's how stakeholders have pushed us to understand it. It's we know for it to matter and resonate to staff. I think this is the definition that we can all unify around. If I then come to how productivity is usually measured, productivity looks a little bit like this. So it's generally understood as the relationship between what's termed outputs. So that's all the activity the NHS does, as we discussed. It's appointment, tests, procedures, whatever else. And to bring those things together, we use cost as a proxy for value. So a more expensive thing is given a greater weight than something cheaper. So an inpatient stay is given more weight than an outpatient appointment, for example. And the relationship with inputs, so staff and everything else. And essentially, if outputs are going up faster than inputs, productivity is increasing and vice versa. And what we've seen over time in the NHS is that productivity increased for about 2.5 decades up to the pandemic. And we know why. We know that patients were spending less time in hospital, for example. There was a shift to doing more day cases rather than long-term elective stays. But when we hit the pandemic, we can see a range of other countries here, productivity fell. And if we look at England, it fell further and faster. So that has been a significant problem. And when I'm describing this as just productivity, that sounds quite abstract. But from our first report, we've estimated that if trends had continued from before the pandemic, the NHS would have been 14% more productive. And that's about £20 billion of additional care. That's more than we spend on general practice. So obviously, the true cost here when we think about productivity is the care that patients don't receive. And again, just to follow through on the context here, that's brought additional focus and attention on productivity, at least on this metric that I've described, which is more about efficiency in part. And so the Treasury set a 2% productivity target for the NHS. So it has to hit 2% each year. And that's higher than it has done historically. That's higher than the historic average. NHS England have developed a measure to better understand it, very similar to the methodology I set out at the start, albeit they do have some additional tweaks and so on. But what we can see if we look at the latest metrics is that productivity is increasing rapidly. If we look across all providers, it's about 3.5% growth in the year to January compared to the year before. So that means, again, more output for the inputs that are available. You can see there's ambulance trust there, as Anna spoke to, so that's going up quite significantly. I will say that the measure is quite novel, especially in areas outside of hospital. So acute and specialist care has been using this type of metric longer, but again, comfortably above that 2% target. So efficiency is going up. That's good news. But why then do we not think this is enough? And I think this speaks then to that productivity paradox that was introduced by Alison. We know that before the pandemic, when we look at the UK and compare internationally, that we already had quite an efficient healthcare system. So if we think about the amount of activity we're getting for the resources going in, generally speaking, we perform quite well. And that's for the reasons I described: low length of stay, quite high bed occupancy rates. So we're using our resources, sweating our assets quite intensively. So high efficiency. But when we come to look at outcomes, and here this is comparing mortality with spend, if we think about effectiveness, the UK does less well. So that's the paradox. We're getting a lot of activity, but we're not necessarily getting the outcomes. So partly, again, this is because what we're counting is activity. And activity can rise because care is working and because it's the right care, or because it isn't. And I think failure demand then is a very helpful lens to explore this. And across the Commission, we've heard time and again examples of failure demand. So I just thought I'd give a few according to the typology that's already been set out. So we know about the operational frustrations, and I'm not going to speak to this from the patient perspective any further because Jacob's done a very good job of that. I think one thing I would stress is this is also a cost that falls on staff. What we heard of described as swivel chair, actually where they're having to go from one system to another because the systems don't actually do the work for them. So they're compensating for systems that don't speak to each other. And it's quite interesting to try and understand why that's the case. The NHS does spend an awful lot of money on technology, but the emphasis is also often on getting the technology in, buying the technology, and less on the implementation and benefits realization. If we think about that rules-based system, Catherine Halliday is somebody on our expert advisory panel who's a radiologist, and she's stressed from the outset, we've seen a very high increase in the volume of diagnostic tests across the NHS, but that those tests might not be of the greatest value to the patient. Sometimes they prompt incidental findings, and that can actually generate harm. And this is again backed up by quantitative evidence, research that the strategy unit have done, for example, looking at A&E departments. And over the course of the 2010s, even adjusting, controlling for the patient characteristics, we can see that you're more than three times more likely to get a CT scan, for example. So again, that's more activity. What that can mean, though, is that the patient that needs the care most is actually having to wait longer. And some of that activity can cause harm. Delays and blockages, again, I think we've heard some very good examples there from the ambulance perspective. We had somebody speaking at one of our evidence events who is a policy specialist in his own right, Sam Friedman, but also a patient with complex health conditions. And he described how he attended a hospital in London that had 99% bed occupancy. He needed a 30-minute stint and he was actually there 3 days. And again, we know from data, the NHS, a significant portion of beds, 1 in 7 last winter, are occupied by patients that are medically fit for discharge. So again, the time is going into caring for those patients, the inputs are there, but they're not necessarily getting the outcomes that they need. And disjointed care, we heard examples, and I think this will be very familiar to anyone, but complex patients, in this case, complex diabetics, who had a range of different contacts across the health service, spanning outpatients, GP, community contacts with different specialists. And again, we know that this group is increasing in size, that the types of targets that the NHS uses to support access and the constitutional standards, that in some respects is fit for patients who aren't yet in contact, but many patients and a growing number with complex conditions are already in contact with the health service. For them, it's not getting faster access, it's the coordination that's really going to make the difference. So I think if we think about the implications for NHS productivity, there are two things, and again, this resonates with what we've heard thus far. Overwhelmingly, I think from what I've described, when we think about productivity as being about value for the money that goes in, there's a very, very strong overlap with failure demand. And I think also some sister concepts, and I think somebody's put something in the chat about value-based healthcare in Wales, and we've heard some instances of that. But all of these things taken together, I think, do have a very strong correspondence. And there's two specific things that I think follow from this. One is that, as we described, activity matters, but it's not enough. And activity does matter. I do want to say that. So just in and of itself, being able to see more patients is and can be a patient safety intervention. If people are waiting less long because you're having higher throughput on the waiting list on the waiting list because you're having higher throughput, that is making a difference, but it's not the entirety. I think to Jacob's point, we're insufficiently responsive to patient experience. And I think also we've started talking about patient outcomes there. The NHS has tried to develop PROMs in some specific areas, but it's yet to really take off. And partly that's because we haven't used it sufficiently to then define the services that we're delivering. What I'm showing here is from the OECD. This is a patient-reported indicator survey set that they've developed, and it is a combination of PROMs and PREMs. And I think this is something the NHS needs to use more to guide service design and to define outcomes. The second thing I want to stress, and this comes to the point, I think, from Alison's first presentation, for productivity also, I think fundamentally we do need to recognise the NHS is a complex system and care is delivered by people. When we look at productivity, it can almost feel like pointing to the variation is enough to drive change, but it's actually staff and patients to some extent who need to be the ones that actually make change happen. But we know that the workforce is under-empowered. So only half of staff feel that they can make improvements in work and less than half feel involved in changes that affect them. And you can see a wonderful quote there from a contributor to one of our evidence events who said, productivity is about liberation. And I think this very much speaks to the failure demand angle as well. It's not making, productivity shouldn't be staff working ever harder. It's about making work better and delivering better outcomes. As I said, it's not a nice to have. Now, I do think from everything that we've said thus far, there's a risk that it sounds like we're in absolute correspondence. And I do just want to then think about some of the places where productivity and failure demand might also pull apart. And I think for that, I think one of the very helpful things that the report points out is, and as discussants have mentioned thus far, failure demand is very hard to pin down and very hard to turn into a single number. It's more readily felt in many respects than measured. And I think even where we do have numbers such as readmission rates within 30 days or daycare sensitive admissions, these are statistics that the NHS has, but behind that's a human story. And in each instance, the clinician is the one that's engaging with the patient. And for them, that may or may not have constituted failure demand. But at the same time, I think productivity is very much understood at the aggregate. And this tension, I think, was expressed here partly in this quote. The individual clinician will see the patient in front of them, but not necessarily see the patient that they're not being, that's not being treated. And I do think that is a tension that's harder to resolve when we're thinking about failure demand. And there's a few instances of where that I think might come up. So when I spoke earlier about low value tests, for example, that we might see. I think there's a question there, who's judging that? Low value for who? And in that moment, with all the contingent factors, the clinician might well judge that of value, but a broader view might suggest that over-testing is occurring. And again, care fragmentation. We know that there are too many specialists perhaps, and you need someone more holistic care for the patient, but each specialist themselves might be adding value. And it's also difficult to ask people to do less of what they're doing well than what they think is contributing value to the patient. So again, these competing lenses can create some tension. And the last one is just to point more simply to the fact that, again, greater efficiency might trump reductions in failure demand. So, for instance, we know that competition in targets can spur higher volumes of care, albeit it can encourage some element of gaming or working to task. But then there's a question, as I posed before, in the individual instance, that may or may not be good for any given individual, but in the aggregate, it might be better. So I do just think these are some tensions to hold on to. But lastly, what I would want to come on to is, from the Commission's perspective, there's certain areas that we're thinking about for productivity, and I think it applies to failure demand as well. But what are the conditions where we can do better? And I'd point to four, and again, it resonates, but it'd be interesting to hear the reflections of the discussants and also the audience. But the four that I'd point to again is better accountability, fundamentally better accountability. That has to be a small number of priorities. We can't have countless priorities and we can't act everywhere at once, but it should increasingly be outcomes that are set that have greater sight of the outcomes that matter. So patient clinical outcomes and patient experience alongside access. Stable planning. Many of the improvements that we want to see across pathways, and even we spoke before about what might be within service and out with service. Even within a service, oftentimes what you're looking for, you need to have teams working together and collaborating. And I think stability is really core to that. And the NHS, we know, far too often concerned with shifting priorities and restructuring, for example, that sever some of the relationships that are really at the heart of making change happen. Third one is freedom to improve. And again, this is partly the sort of process burden, the assurance burden that the NHS operates under. It's also where incentives can be applied, and I made a case before, but incentives sometimes point in the wrong direction. So where we have activity-based incentives, for instance, for something that we then need to shift. And the NHS England, I should say, is very mindful of this in how they think about productivity, but left shift might run counter to the way it's currently measured. The last one, and I think it overlays all of this, is capability. And something we find in our work, the NHS is too short in some of the capability that's needed. So again, to see across pathways, which came up before, you need data. You need the data to be able to see across pathways. You also then need the skill set to identify the bottlenecks and understand how to make improvement. And that's operational skills, it's system engineering and everything else. And the only other thing I'd mention there is management. The NHS, we know, is undermanaged. And I think that's a form of accountability too, that isn't based around metrics, but again, having that as a source of accountability and having an understanding of how work's being delivered, I think can help address both productivity and failure demand. I was going to stop there, but again, it'd be very interesting to hear the audience's reflections and the discussants as well.
Stephen, that's excellent. Thank you ever so much. And you've actually been touching on a few points that have been made in the Q&A box in the final couple of slides that you've got. Lorna, please could you bring everyone back in? Please could you bring Alison, Anna, and Jacob back in so I can see them all. Thank you. Have Jacob back as well so I can see. Excellent. That's good. Thank you. I've been trying to harvest questions out of the Q&A function, which has been very busy, and I'm trying to sort of synthesize it into a few themes, and I'm also mindful that there are 4 of you and probably about 20 minutes or so left. So you can see I'm signaling to you now to be relatively brief in your responses. If I was going to try to summarize and pick out some of the more important themes, I think there are 2 things that I'd just like us to focus our time on. The first is the concept and its measurement, and then the second, and I'd like to spend more time if we can, is on its application. And the basic question of, okay, yes, we've seen it, what do we do? But the question of of the concept and its measurement. It's interesting here, just to try and pick out a few fragments from the Q&A. It seems like a very negative thing. It has failure in the title. Is this something that's going to engage people, get them motivated and fired up? How does it relate to existing concepts we already have? Stephen, you've mentioned value, but there are things like shared decision making where we're attempting to do a similar sort of thing, aren't we? And then a question on the concept of, well, in a sense, it's dead easy defining value in a market because it's what consumers want. Defining value in healthcare? Stephen, you've touched on that. You can do it legitimately from many different angles, can't you? So how do we square that out? So I don't know who wants to start, but just something on this, on the concept and some of those themes that have come through from the Q&A. So who'd like to get us going? Jacob, we're going old school. I like this. Thank you. Okay, so now you've set us going. We're all going to be using our hands. So thank you, Jacob.
On the language about failure, because I touched on this in the earlier conversation I had with Alison. I think it is quite helpful to keep it as failure demand. And the reason I suggest that is that it is failure, and it will concentrate attention on particularly from some of the maybe less clinical professionals and less policymakers have to focus on this, but more finance directors. It's an audience of people who we need to convince to focus on this. I also think the NHS has a habit of giving positive names to things that are bad. Does anyone remember the success regimes, which were for hospital trusts, which were failing, which everyone knew was just like, just call it what it is, and we can get attention on it and move on, rather than trying to rebudget and go, it isn't really failure. Like, it's no one's fault. It's not a bad thing, but it is still a failure.
Thank you. Anna, you were next with your hand. This is lovely. Thank you.
So I'd add to that, and I'd agree, and thinking about it from the paramedic ambulance service perspective. So handover delays, for example, that is failure demand, and ambulance service crews know better than anyone where they're dealing with instances that they shouldn't be dealing with. So there's something about saying what it is instead of dressing up as something else, being honest and frank. And I think needs to have that narrative around it, that this is nobody's fault. It requires a different response, collaboration, and so on. But I think that it is unhelpful to move away from that term, because it will resonate with so many. And I'm thinking from an ambulance service perspective, will resonate with so many clinicians. Thank you.
Do you think we can use it in that blameless sense? The idea that it's caused by wider system factors turns up quite strongly in the Q&A. Do you think we're capable of that? We tend to want accountability for things, don't we? Accountability for failure. Who's on the hook for? Do you think we can hold that?
I think that's part of the shift that we need, and I think that aligns to looking at the patient. A very good friend of mine who used to lead on patient experience for the ambulance service, all too often the patient's an inconvenience that we sort of try and work around, whereas they should be at the heart of it. And as I said before, we should be orbiting around that patient. And I think moving away from the blame bit can be helped by that. This is about the patient, not a clinician, not about an organisation. So I think that can help in that research construction.
Thank you.
Anna, could I ask you, I'm really interested about, and you gave some really good examples, and I think across the commission, we've seen where you come across what looks and feels very much like good leadership, where leaders are willing to understand that change needs to happen, and again, to shift away from blame and bring people around the table to think about common problem solving. But I only wonder, from your perspective, an ambulance trust, for example, what are the conditions for that to be made more readily possible in the NHS, and where does it fall down? Where does blame start to creep back in?
So I think, and again, the point that Jacob made around bravery, I think for a multitude of reasons at the moment, we need brave, courageous leaders in the public sector everywhere, more than ever. And I think it's about leaders taking up that space that is theirs. If they're a leader of an NHS trust, then arguably they have that those conditions to step forward and into that collaboration space from a system leadership's perspective. And I'm thinking again of South West Ambulance Service that has been sort of pivotal to some really key change with regard to hospital handovers. I think people need to go for it and take that space and claim it. And maybe controversial, I think there's a lot of people that get paid a lot of money, and I think part of being a leader, a well-paid leader, is being brave and bold and putting your head up rather than putting your head down. And now's the time to get out of our lanes from a system perspective, not look down, look up and out, and think about the patient, because all too often we don't. Very quick reflection. I remember years ago, when I was much earlier on in my career in the NHS, being sort of somewhat struck that the patient hardly ever gets referenced. We need to get right back to that, and thinking, oh, is this me that's out of sync, and why is this? But I think I'm really pleased to sort of see what I think and hope is coming back to that, and patient being primary and others being secondary to that.
Stephen, can I put that question to you? This question, because there's a strong intuition in this concept that all you have to do is define value from the patient's perspective, and everything will then follow. But some of what you were saying was, well, yes, but patients have radically different values in some respects. Aggregating them is not trivially easy. Also, the system has a perspective on value because it's got the resource allocation question as well. I don't know if you want to say something about that, these different perspectives on value and what that then means for this concept.
There's a couple of things there. I think part of the tension that I was alluding to as well in the chat is that obviously different teams and units might have their own perception of the value of the care that they deliver. And so I think there is some tension between what I think we all will agree, you need to empower staff to be able to make change. But for each individual unit, you might not want to see your own resource diminish or reduce. And sometimes doing better might mean that, in fact, you need less resource. And I think that probably is quite a difficult challenge. And the way that we tend to incentivize improvement in the NHS, often, Foundation Trust in the past, okay, you'll get more money if you do well, or individual teams might be rewarded with more resource if they do well. And so I think there's something there's a tension there. I think thinking about outcomes, I think that I'm particularly interested in, again, PROMs, I think, is a way to really centre much more closely around clinical outcomes. But of course, it isn't that easy. There's lots of different conditions. How do you square across different conditions? That's not necessarily easy. But also for some patients, if you have complex needs, or if you're towards the end of life, you might not actually be improving, you might be deteriorating. And so then what's your counterfactual? So I think there are lots of measurement challenges, which isn't to say that we shouldn't do it. I think in some ways that ends up being a fudge for why we don't get on with having better outcomes measurement. I think we should do it, but I think we need the capability as well. We need the analytic skills to really understand what that information is telling us. And I think where PROMs have fallen down in the past is because we haven't put that resource into using it and using it well.
Thanks. I want to shift us on to this question of what are you going to do about this? There's quite a lot, of course, in the chat about, okay, well, fine defining it, fine talking about measurement, fine talking about causes, but then what? I just wondered, Alison, if you got any further reflections on the concept, though, because you entered this piece of work thinking, oh, here's a potentially useful concept for the NHS. Did you have any sort of reflections at the end of all of that?
I guess for me, I guess it sort of highlighted, I suppose, for me, I suppose it does come back to the cultural issue. And I think one thing I've noticed is over the last few years, all those sort of spaces for collaborative learning have been sort of cut back an awful lot. So there's not an awful lot of space for people to learn together and for that sort of collaborative, interdisciplinary type learning, which really would underpin the right approach to this, because it really does need that sort of those spaces for people to come together and be able to have these conversations. And so things like developmental peer review doesn't happen as often as it used to, and things like that, which sort of set the tone for this kind of approach. And maybe things like the learning health system approach could be interesting, because that sort of talks about learning cycles, and you could almost imagine that would be a really interesting way of thinking about some of this. But yeah, I guess that I'm going to come from this from a knowledge perspective, and that's really what struck me, I think.
Right. Okay. Let me spend the last 10 minutes then on this question of application. So I'm interested from each of you really, but what does this now then mean in terms of addressing this problem that we're sort of pointing to? And in particular, there's quite a lot in the Q&A about the types of skills that would be needed to go at this effectively. So I don't know who would like to get us going. Is that Jacob? Are you buying the slides?
I'm happy to kick off again. So I think two things on this. I think actually when you've identified, or you think you've identified a failure demand issue, I talked about don't worry too much about the measurement thing. If your gut instinct is telling you this is a problem, or it's likely to be a problem in more circumstances, I don't need to record every incident of it to know it's an issue that needs fixing. So a good example of that might be, we've seen in the past an issue where blind patients are being sent letters, right, that they're not in Braille format. You don't need to wait until you've got 100 or 1,000 blind patients and raise that issue with you to know that that might be an issue. So actually you can use just your common sense at times as leaders to identify why you might have a failure demand issue as a result of things like that. But then how you resolve it, don't think that you can come up with the answers. The answer isn't just to send a Braille format letter out to people, because it might not be the right appropriate format. Actually, you need to involve patients who are affected and living and breathing the failure demand experience in the process of designing whatever comes next. So and that's where I think there is a large resourcing and skill gap in the NHS at the moment. We don't invest time and effort in training elements of the workforce to be able to do that engagement and do it well. And so you end up with people who are trying to either tack it onto their already very busy day jobs to do it, or just not doing it. And you end up designing solutions that create failure demand in another way, because you haven't involved people who will be looking at the whole pathway from their experience. So that I really make a plea for that is one of the key ways of, once you've identified the problem, the solutions come from working with partners, with the patients and the clinicians delivering the care, not just your bright spark idea that you want to try and then put in place.
That sounds sort of slightly more time consuming than the traditional approach of, I've seen the solution, we just need to get on with it. Do you think it is, or is it worth investing in the
I know it's never more time consuming in the long run. It might feel like it in the moment, but you're much more likely to create something that's going to work first time and avoiding later unintended consequences if you've gone through that process. And even if the outcome of it was just your community felt more involved, your community felt more empowered, as though they had a say in how care was designed, that is a really valuable outcome in itself. And so I think that some of that changing the culture and shift towards that. So when you come up with a new problem where you really did need their input, it was going to be integral, they're going to be more willing to engage because they can see that their views are taken on board and they're valued. So even if it feels like it's taking longer, that investment will pay back in the long run.
I think that feels very true. Again, the idea of NHS tech, where we do, I think we need to spend more on tech, but we spend a lot already. And again, taking the time to make sure the systems are in fact well designed to solve the problem, rather than just something that can maybe achieve the procurement exercise faster, I think feels like a really big source of gains. I'm really reminded of the adage, slow down, we haven't much time. It feels like that applies to the NHS often.
Alison,
Do you want to go, Alison?
Oh, sure. I was just thinking that I think the skills is an important point, because that came out in all the people we talked to about the need for sort of systems thinking. But I think there's probably an awful lot of pressure on operational managers, and Stephen alluded to the fact we're undermanaged, and so I think there's something about support for those people. It's not just a skills issue, because in some organisations they might feel like they're swimming against the tide a little bit, and perhaps it's an uncomfortable position to be in, perhaps, to sort of be trying to address some of these issues. So I think there's something about the support, and I know there's networks like Proud to be Ops and things like that. So perhaps there's a role for those in terms of providing some of that peer support as well.
Annie, you had a reflection?
Yeah. Thank you. Yeah, so I think the improvement point that's come out a lot in the Q&A it is really, really key. That continuous improvement, move away from the sort of blame culture where you're just building what you're doing, and everybody fails, don't they, all the time. So accepting that we all make mistakes, we all get things wrong, but it's what we learn from that and how we improve. I think the culture bit is massive, and being open-minded and common sense, and we see this everywhere, don't we? Common sense can become secondary to standard operating procedures, too much infrastructure, regulate, all sorts of other things. And if we can sort of take a step back, and I think about what we would want if it was our mum, our child, our partner. So there are a few of my reflections, and what I was really enthused by, Marie Curie's palliative care national summit the week before last was individuals, and there were various different individuals, but stepping into that system leadership space across the country. So there was a palliative care consultant in Herefordshire who was like, right, I'm going to, with colleagues across the sector in palliative care space, step forward to make sure we're doing our best for palliative care patients 24/7, working across primary, community, acute, and so on. In another place, it was a GP. So just taking those steps, going for it, not waiting for the permission or the instruction, going for it until you're told not to, essentially. I think that's what we need. It comes back to that bravery point. Thank you.
And one thing I think implicit in all of your answers is a broader systems perspective on this as well. That I've heard that very loudly in what you've each said. I just would like to give you each a minute now, just to sum up. I mean, you know, we're at the end of this piece of work. There are things that we might do in the future with it. You've heard each other's perspectives on it, and you've seen the Q&As coming through as well. Could I just give you, you know, just each a minute, just to sort of give your final reflections on this topic. I'll just go around my screen. That will make it easier from a chairing perspective. Jacob.
So I think the thing that sat with me is the links between the failure demand and the outcome measurement. And I think there's something what Stephen was saying about that we're not been particularly good at using proms we have got. I think some of that is because the outcome measurement differs so much from one area to the next, one service to the next, one condition to the next. And if we had a broader outcomes framework that was more driven and structured around the real world outcomes that patients want to achieve. So am I living pain-free, or am I living with able to go back to employment, or whatever the outcome might be? There might be a better way of linking the failure demand to how it's driving those real world outcomes that are consistent across lots of different services. And so I think that's sort of where I think would be some useful thinking to go next.
That's great. And Anna, can I give you a minute?
Yeah, so my final reflection would be, and again, thinking specifically from the ambulance service perspective, so we feel that we're sort of on an evolution from where we're at now. If we think about the time targets, what we're sort of serving, what we have been serving, that has driven perverse behaviours and means that we're not always providing patients with the right care for them. And we've thought a lot, again, looking at the work that's happening in the Welsh ambulance service, that's focusing much more on outcomes, looking at scheduling and scheduled care and so on, looking at how we evolve. So this it's not a kind of big bang thing, we're not going to get there overnight, but how small steps can take us in the right direction. And I think there's a huge potential with this to improve staff morale, to take staff with us, which is essential given where we're at. So I think it's exciting, and a really welcoming opportunity to speak with you all this afternoon. Thank you.
That's excellent. Thank you, Anne. And then Stephen.
I would say something similar insofar as, I mean, from a productivity perspective, a health system performance perspective, I think everyone must know how tight funding is, and it certainly looks like in the near future that's going to continue to be the case. And I think simultaneously, I think across the work that we've done, but whether we're thinking about productivity or more directly about failure demand, it's just so visceral, some of these failings and failures. But paradoxically, I think that is very much, I think to Alison's blog, it's a source of hope and optimism that in fact, even within the budget that we have, or with the budget only growing slightly, we can do much better. And I think this report's a great contribution to thinking about that.
It's fabulous. Thank you. And then Alison.
Yeah, I think for me, it's just coming back to that cultural point. And I think I was at the Knowledge Mobilisation Forum like 2 months ago, actually. And Lewis Hu from the Science Ceilidh up in Scotland just came up with this sort of soundbite, which I thought summed up, it's sort of be kind to people but tough on systems. And I think that's kind of what we were essentially talking about in terms of, you know, we want to have collaborative conversations about this and bring in different perspectives, because I think everybody brings a slightly different view of the system, and I think that together we sort of build a more complete picture, I think. And I think that will just really help to sort of start to set that culture for learning and collaborative working.
That's excellent. Thank you. Listen, let me close the session out then. First of all, on behalf of the Strategy Unit, I want to thank everyone who's attended. We had more than a couple of hundred people on at the peak during the session. So thank you everyone for coming. Thank you for your contributions and thank you for your questions. And then on behalf of the audience, if I can, I'd just like to thank the panel. So thank you, Jacob. Thank you, Anna. Thank you, Stephen. And thank you, Alison. I know it wasn't the aim, but I certainly really enjoyed that session. So thank you very much. And I just encourage people to look at the reports, which is on the Strategy Unit website, and then continuing conversations on LinkedIn too. So thank you very much. Enjoy the rest of your afternoons.
Thanks, folks.
Thanks a lot.
Thank you. Thanks, everybody.